Okay. Me okay? Good, okay. Now, I don't like to be tethered to the podium any more than anybody else, but with Paul having the lavalier on at the beginning. Better? Better? Okay. Little better. All right. I just thought that was great. You know, I had an opportunity to chat with Paul previously and just thought that kind of stuff, you know, I'm inspired and feel really good about a lot of those things he said. I think we do a lot of those things here. And I mean, all of us in Colorado, this environment. I think we do collaborate better than a lot of places around the country. And it is about the people, right? And that's why I think we're still doing this 13 years later and people are coming. And you know, it isn't just listen to me talk. That's not why people are here. It's because we're all doing this work, and it's what brings me back every year is reconnecting with the people that give a darn. And so it re-energizes me too, just like he said, late in career. And he didn't use the word old. I prefer the word old when he talks about more seasoned leaders, right? But I'm like, not seasoned, I am old. But I want to talk a little bit really briefly, 10 or 15 minutes, some highlights about what we've done in the last year. Our annual report is out. You can see this on the website and download it, so I'm not going to go through all of it. But we've been doing a lot, and we have shared those same goals, moving the needle in certain key focus areas for us. And one of those is expanding access to treatment. And it has been for several years. This is one of our goals. It's not the only area, but to work with our MAT expansion program, we have state funding for this. And even though the ongoing funding, additional funding was cut, was not appropriated, we fought like heck and kept this so it wasn't repealed. It was just not appropriated. So the program still exists. We had some carryover money from the last couple of years because it's really hard to stand up treatment. And even if you have money, people will tell you. And this crowd knows this. Even if you have a lot of money and you say we're going to throw X amount of money at it, doesn't mean you can treat X amount of people right away. It takes time to stand these things up. So there's residuals, and we are very, very good about squirreling away our residuals and now making another program out of the residuals. So now we're going to expand into bringing pharmacies into the mix, as we focused on advanced nurse practitioners and PAs, focused on rural areas, focused on different kinds of ways, or how can we leverage things differently and create more access where it wasn't before. And that's the purpose of this particular program. And now we're going to try to loop in pharmacies as a potential access point for initiation of MOUD in the pharmacy setting, which again is very new. It's working in some other states, but it's a wonderful concept, and we're leaning into that, and we'll hear more at the panel discussion. Public awareness efforts. You've seen some of our stuff. Our flagship program, thank you, Hillary, is Keep the Party Safe, is our latest, and we've had various public awareness campaigns over the years. And we've learned, just like Paul mentioned, we've learned from the broad strategy to get much more focused and much more targeted on where are we going with what messaging and how do we deliver it and how do we reach people and then move the needle in terms of awareness and then behavior and then outcomes. And you have to do sort of in that order, right? You can't just get to the outcome magically. It has to be a process to try to get there. And that's our strategy to do it. And this one has been wonderful with the leadership of the work group and Hillary coordinating and our creative partner doing so much more. It's really terrific. And we're getting you know, just what we hear from people about this campaign is it's tremendous. So thank you, and major props to Hillary. Some of our public awareness efforts also are focusing on reducing stigma, as we want to obviously reach people and make them aware of overdose and naloxone, of course. But stigma still, you know, 13 years ago it was, and 130 years ago it was, and however many years ago it was, has always been public enemy number one with this issue, right? It's still, and it still is, and you still talk to people, and it's just, for me, I thought, you know, when will stigma die, right? Nope, not dead. So we're going to keep fighting, and we're going to keep beating on it until it dies, darn it, right? And we have to keep doing this. So ways we're trying to do it is we work with our affected family and friends work group, for example, to do what's called Stories in Black and White, which are basically exhibitions of sharing stories, but also engaging people. So it's a way of doing this more in an interactive way than simply saying, all right, we're going to post pictures or we're going to do this kind of thing and catalog things. But how do you make this you know, sharing the stories and make it interactive and engaging with people? So we've done this with various places and are doing more of them. And again, Hillary, major props. It's Hillary Day. I think it's Hillary Day. So at least it's leading off with that for sure. Next is educating providers. A large part of what we do, obviously, is provider education. We are on a Health Sciences Center campus sitting here. We do a lot of provider education on this campus with aspiring and soon-to-be providers. But most of our work, frankly, is out in the community with providers that are already there that may not still be connected with the health systems. We have relatively light continuing medical education requirements in this state, especially for physicians, but for some other groups too. And I just don't view it as like that's a lot of education people have to get. So we keep working on how do we educate more providers about best practices, not only for opioid prescribing, but benzodiazepines, how to treat, recognize and treat use disorders, to be more comfortable with it, because people claim this is very difficult, and pharmacologically and medically, it ain't. It's not complicated. It's a whole lot more complicated if you want to treat asthma or diabetes or hypertension. Really complicated pharmacologically. Very easy to treat opioid use disorder pharmacologically. It's getting people access and being able to do it, but the medicine and the pharmacology behind it, I don't like. That's why I tell the reticent clinicians, it's a non-issue. Do it is the issue. Are you going to do this? And we're trying to engage to get more of them to do it. So we do a lot of education this way. We partner with a lot of organizations like COSAM and COTOD, and how do we partner better to get this kind of education so that all physicians should be able to routinely recognize and treat opioid use disorder and other substance use disorders. Every clinician. Because you can't talk to them. I say, I refuse to talk to someone with asthma. I don't know what it looks like. I can't recognize, I can't diagnose it. I don't know what it looks like, and I can't treat it. Bull. And it's way more complicated than treating a use disorder to try to manage somebody's brittle asthma. And so, that's what we're trying to accomplish. Then supporting affected families and friends as well. It's not so much that it's like a help group or a support group in the classic sense, but it's how do we engage with people to share the stories, to make an impact on building bridges, on policies, on programs. How do we do that so that it goes beyond, yes, we want to share the story, but what can we do to multiply and amplify that story so it makes a difference on the lives of more people? And that's the goal for our programming there. Assisting jails is a new focus area for us that we've always done a little bit with, whether it's recovery courts or what formerly called drug courts, but really recovery courts and that kind of thing, now to extending to working with jails that are trying to implement these MOUD requirements. Thank goodness we have them. I love them. And how can we do more MOUD in the jail setting? We know the carceral setting is huge for this. Now we're getting requests from how do we work with parole and probation officers, community corrections. How do we get there? That could be one of the biggest areas that we really need to focus on right now, because that continuity, post-carceral, back into community integration, critical point, highest risk of overdose that we've ever been able to quantify is in that period, the 2 to 4 weeks after release. So we need to work better with this, and we're doing this now, partnering. And again, it's all through partnerships to start, right? How do we build bridges and engage more? So it's wonderful to be able to do some of that work. And then supporting all things recovery. We're all about recovery, right? Everything we can. Various RCO events, hosting these kinds of conferences, helping to support the rollout of the Recovery Friendly Workplace Initiative in partnership with the School of Public Health here and the Center for Health, Work, and Environment. Again, this is a huge priority for us in this work, and lots of things going on that are really very encouraging. So I'm excited about that. Then how do we assist communities? Our ERS staff, external relations strategist staff, help us go out into communities and work with, and we've done this from the beginning when it was just Jessica in 64 counties. Now it's 2 people in 64 counties, and it was 4, now it's 2, sadly, because the budget, we'll talk about that later, but still doing this work on the ground, living and working in the communities. How do we engage and ask people, how can we help? Not here's what you should do, it's how can we help is the question. And this is what we learn. How do we help with community grant writing? We had our grant writing assistance program, spent all the funding through, and that was the purpose. Spend all that money, get people to get more grants, and end up with $2 million in awards off of $80,000 worth of funding. So the ROI is off the charts on this program. And the legislature even agrees. Love the ROI, don't have any money to put into it. I don't care how good your new refrigerator is and how much money it will save. We can't buy the new refrigerator, even if it's a great idea. So unfortunately, the budget right now isn't really allowing for it, but we're trying other sources to see if we can't fund it, because it's been very successful to help people write grants that don't have time for grant writing. Things like that. How do we help with strategic planning? How do we partner with local hospitals or other provider groups, connecting organizations, working with the libraries? Most as an example recently with people in the library sitting, so that we can make sure there's access to and awareness of naloxone in libraries. It's a public use space and need to have naloxone there too, and other educational materials and connection to resources for prevention, intervention, harm reduction, and treatment. How do we do that? So again, more bridge building. And connecting so many people with these assisting agencies. We partner with all of our state agencies who are tremendous at BHA, CDPHE, DORA, HCPF, to do this work, and how can we collaborate? And it's really been very encouraging to me. If you think of each one of those as a giant organization on their own, and someone's saying, it's giant, even they're getting whittled away as well. Everybody's facing the same issues. But how do we partner across these agencies and do this? And other nonprofits, other coalitions, the ROAC facilitators, Illuminate Colorado, really it's all about these partnering, and the external relations staff help us do that. So with that, how close did I do, Jan? Am I close on time? Wow, look at me. That's miracle. That's why I told I can do any amount of slides in any amount of time. I'll just speak faster. I'll just keep rolling through these. But it's been, it's all about, you guys. That's why I want to say that at first. This is how the work gets done. Is everybody in the room? We try to help coordinate, bring an opportunity for a forum like this, convenings and stakeholder engagement. But our programs are a few out of 1,000 programs that are going on around the state that we're doing. So we do a little bit of programs and try to support them. And I appreciate everybody being here to give time to this again. So now I will give over to Christine Demont so she can come and talk to you about Colorado drug overdose data and trends and some of the latest data that we are seeing. Thank you.